Hey everyone, my name's Donnally. I'm a spine surgeon in Dallas, Texas. And today I'm going to go live to go over a couple different things about the main thing I'm going to talk about today are two things about back pain. There's going to be the Intracept procedure, which I know many people have heard about. That's where it's a minimally invasive thing. I don't do the Intracept procedure myself. I actually have a pain management doctor in our group that does the Intracept procedure. Essentially, what that is when you have this needle that goes down the back part of the spine and it burns the nerves inside the bone to reduce back pain. That's what the Intracept procedure is. In terms of how that compares to an ALIF, so that's one of the things I'm debating today. Intracept procedure versus ALIF. Again, the Intracept procedure is good for back pain that doesn't have like an identifiable source necessarily, or when there's something called modic 2 or 1 end plate changes. That's when there's a lot of bone swelling at one vertebral body on the other, and there's bone rubbing on bone here. Well, the good thing about the Intracept procedure is it's what mostly done by pain management doctors, is that it's a good way to burn the nerves in the back part of the spine that are coming from the bone. So these aren't the nerves that are coming out here. Those aren't the nerves that are coming from the facet joints. These are the nerves that are actually in the bone. And this Intracept procedure is kind of the new thing. So the reason that this Intracept procedure became famous recently, even though it's been around for about 5 years, is this is the thing that Carson Daly had. So Carson Daly had this surgery about, I don't know, 6 months ago, and he did pretty good for a while. He did pretty good for a while until he didn't, and then he had to get the ALIF procedure. So I think that's a good debate in terms of, well, what's the difference? The guy still had to get a fusion after this non-invasive surgery. So should he have just done the ALIF surgery to begin with? Should he have done the ablation surgery to begin with? Here's my thoughts on that. And I appreciate all the likes coming through now. That kind of helps promote this video to other people that might be going through the same pain. My thoughts are this. If you can avoid a big surgery, if you can avoid a fusion surgery, then that's a great thing to do. The way that Carson Daly did it, again, I don't have his medical record. I don't know the whole history of it. But the way that Carson Daly did it is that most of his issue is back pain. He didn't have a lot of radiculopathy. That's shooting down pain. That's pinched nerves. And so he tried the more minimally invasive option of burning the nerves in the bone. Now, I know a lot of people watching this are like, I've tried the ablations, I've tried those shots, they don't work. This is actually a little different. And again, I'm not a spokesman for the Intracept procedure. I've never even done one. I've never even seen one done. I just know about it as a source to provide a relief of back pain. But again, that Intracept procedure is like an outpatient thing. Tiny little probe goes through the pedicle of the bone, and then it burns out the nerves back here in the bone. So it doesn't hit the facet joints. It actually hits the nerve just here. So the reason that the Intracept procedure is good is it's outpatient. You go home that day. That's a nice thing to do. We have a pain doctor in our group that does it. I don't do it myself. So that's what Carson Daly had. That's good for back pain. There's certain qualifications you have to have. One, you can't have anything called anterior listhesis or spondylolisthesis. That's when one bone slips forward on the other, kind of like that. I was going to hold that there. When one bone slips forward on the other, that's anterior listhesis. That's instability. So you can't have any instability in the spine or else it won't work. 2, you can't have a tumor. 3, you're not supposed to be having shooting down pain, numbness and tingling, shooting down the legs. That's called radiculopathy. When you have radiculopathy, that's from a pinched nerve or a compressed nerve. So those are things that people shouldn't get the Intracept procedure for. Again, I appreciate all the likes and comments coming through. I'm going to get to the comments in a second to kind of run through the difference between the two different types of procedures. So he had the Intracept procedure, burns the nerves. And in many people, there's many good studies out there. If someone gets really bored and wants to find like the top studies, go to a website. It's called pubmed.gov, med.gov, pubmed.gov, and search Intracept procedure. And from there, you can kind of read some of the new studies. Now, the journals that are the best, because you're going to see there's like a study from the West Turkish Journal of Neuroscience. And I'm sure that's a good journal, but the journals that you should focus on when you're reading about something, there's one from 2018 or 19, I forget. That's one of the randomized controls trials. It's in Spine Journal. There's another one in the Spine Journal. Those are the journals you want to look at when it comes to this procedure. Again, I have no conflict of interest on this. I take $0.0 from this procedure. I've actually never even seen it done. I just have a pain doctor in our group, and she does do the surgery. So I appreciate the likes coming in and those questions. So the Intracept procedure is a good source of getting rid of that back pain. If you compare that to an ALIF, an anterior lumbar interbody fusion, which now switching to the other side of this argument is what Carson Daly ended up having. That's why I think Carson Daly is a good case example on this, because he had both. He tried the less invasive, non-surgical, I guess it's technically a surgery procedure, same difference. But he tried the less invasive approach, didn't work for him, and then he ended up having the fusion surgery. So the fusion surgery in ALIF, again, I don't know his clinical record, is where they go through the front and they fuse the disc space. His, I believe, was an L5S1. That's when you have a vascular surgery. They make an incision this big and they go through the front. They take the pressure off that disc. They open up this nerve root right here by putting in that cage, and they open it that way. So that kind of goes to the whole debate. Well, what's better? Was it the Intracept procedure? Was it the ALIF? It's a little hard to know. My argument is this: if you're having shooting down numbness and tingling in the leg, if you're having butt pain, if you're having something called radiculopathy, the Intracept procedure is not for you. And the FDA qualifications for it, that was actually something called a contraindication, meaning you shouldn't have that procedure if you have that. If your back pain is shooting down the leg, numbness and tingling, locking up on you, then that could be from a pinched nerve. And that pinched nerve could be from a disc herniation or arthritis. Depending on all of these other factors, could depend on whether, one, you even need a fusion, or two, if you need an ALIF, where you go through the belly and then you usually, it depends on your situation, you back it up in the back. So that's kind of the whole deal in terms of the Intracept procedure versus the ALIF. Not necessarily apples to apples, but I always recommend, if you can avoid a bigger surgery, you should do that. The Intracept procedure is a good way to do that. And again, I know I sound like I'm a walking ad for the Intracept procedure, but I take no money from them. I've never done it before. I've just had patients through our own pain doctor who's experienced good relief from it. And, if you can avoid a big surgery, that's great. The big surgery I'm talking about is no joke. It's an ALIF, anterior lumbar interbody fusion. Incision, depends on how many levels, usually, 3 inches under the belly button. You're going through, you take out this degenerative disc space, and you place a titanium 3D printed cage there. That does a couple things. One, it gives you lordosis back, and that's a key thing. That's this curvature back in the spine. That's key. Two, it jacks open this disc space so that the nerve that's being pinched in the back, you can imagine if this is collapsed down, that nerve's now jacked open. Well, that nerve's wide open. That's great. That's what you want. Three, if you're having back pain from the bone rubbing on bone, then the ALIF is good there to kind of isolate that one area. Now let's talk about some of the pros and cons of both of these. The advantage of the ALIF is it takes care of that level forever, and that level's done forever. You're never going to get arthritis at that level again. The downside, besides surgery, pain, rehab, all that stuff, is it's a fusion. That sucks. Fusions are good in some situations, bad in others. Depends what the indications were. For just treating back pain, a fusion's not a perfect option. And I say that, spine surgeons like to say that we don't do surgery just for back pain. Well, that's not 100% true. The reason that spine surgeons, including myself, say that is surgery for back pain is less reliable. We'll do it. I don't do it right off the bat. I like to get to know the patient. I like to try non-operative things. But if there's like one level that looks awful and everything else looks perfect, okay, fine. I'm not going to torture you forever. I can do a fusion for that. If you have one level that's shooting down, numbness and tingling, it's a pinched nerve, well, you might not even need a fusion. You might need something called like a laminectomy, and that fixes degenerative disc disease. I see some of those commenting, and I appreciate that. So there's just a whole range of different options. Who needs a fusion? For sure, people with fractures. That could be pars fracture. That's when this part of the bone in the back called the pars has a crack. Usually that happens when you're in your teens or your adolescence. Hyperextension sports, linemen, tennis, football. I said that twice. Volleyball. When you're hyperextending back, it could create a pars fracture. Well, that hurts. That's okay. Those usually heal. But sometimes over the span of years or decades, that refractures, your back gives out on you again. And over, slowly you start wearing out this disc space. So I have a couple videos on YouTube and on my own platform. I appreciate all the likes coming through. When you like this, it helps go to other people that might be having the same problems or conditions you're having. So doing the likes really kind of helps the algorithm know that, hopefully I'm preaching the gospel over here, preaching the truth and trying to just give out nice things here. But people that need a fusion are the following. One, and that could benefit from a fusion. That doesn't mean they need it. That could benefit from a fusion. Anterolisthesis. That's when one bone slips forward on the other. Two, when you have severe foramen are where these nerves come out, stenosis, that would not be appropriately addressed with a laminectomy. A laminectomy, not to use all these medical words, is when you burr out this back part of the bone here to clean out the arthritis. But sometimes if it's so far out to the side and you have to remove that joint, move that facet, you might have to take that joint, that facet out. That's a case where someone might need a fusion. Another one's a tumor. That one's an obvious reason to need a fusion. Trauma, obvious. Infection, kind of varies. If you have to like remove a ton of bone to get to that infection, that could be another. So in general, I think it's totally fair to say that spine surgeons are doing too many fusions. Very broad generalization, and that's putting, I don't know how many spine surgeons there are in the world, maybe, 50,000. I have no idea if that's accurate or not, putting us all into one boat. But I think it's important to ask your spine surgeon, well, why do I need a fusion? Why do you think I'd benefit from this fusion? And that's a key thing to kind of debate and go over. But that's why I just want to highlight one more time this new, I say new, the trials, the FDA trials have been around. They were doing it in like 2017 or 2018, but that Intracept procedure that I think is a pretty cool hot topic and something that people really should look at. Again, I say that I'm not marketing it. I don't do them myself. I don't make any money from Intracept procedures. So I really feel like I have no conflicts of interest. I just read the literature. I understand the peer-reviewed science. And that's just a way that I try to help my patients avoid a bigger spine surgery if they can do something less invasive. Again, I don't do it myself. We have a group in our group, Texas Spine Consultants, Dr. Lee. She's been doing it forever. And I only kind of realized there was a big hype about it when Carson Daly did it. And then I see all these groups in town advertising they do it. I was like, well, heck, we've been doing that for years. How come it's now just becoming so popular? Didn't even know it was that cutting edge until I started looking into it. And Dr. Lee, my pain management doctor, was telling me about it. But in terms of debating that outpatient procedure where, and again, it's not burning the nerves. It's not burning these nerves in the back. They're called the facets. It's not that. Many people I see commenting say, oh, I've had the rhizotomies. I've had the nerves ablated. It's probably not the same thing. This is kind of a next level deal where you put this probe all the way deep into the bone and burn into the bone. Intracept procedure. Comparing that versus ALIF for back pain, for sure. Again, what causes your back pain? That's a whole different debate. Is it the degenerative disc? Is it the facet on the left, facet on the right? Is it the instability? You really got to get the diagnosis of the back pain under control. And that's why, again, I appreciate all the likes coming through. It kind of helps this video get promoted and other people be seeing it. But that's the whole deal there. So now that I've kind of talked a lot about degenerative disc disease and what's the best treatment, Intracept versus ALIF, well, they're probably both great. I guess the whole goal is what's most reliable for you, what is most reliable in that provider's hands. There's some surgeries out there that I don't think I do a great job at, so I don't offer them. There's some surgeries out there like that I think I do a great job at, so I like them more than others. For instance, disc replacements. I love disc replacements. I think I do a pretty darn good job of a disc replacement, so I like doing disc replacements as opposed to someone else who might think they do a pretty good job of doing an ACDF or a neck fusion. They might push that on the patient more than a disc replacement. It's all kind of based on what you think you're good at. If you think about your own profession, there's probably many ways to do a certain job, and you have a different skill set, you have a different training, a different understanding, or three-dimensional anatomy. So with that, I'm going to kind of jump in and answer some questions here. Someone's saying, what should I think about before considering major surgery? Well, I think some of the key things you should ask is, what happens if I don't get the surgery? What happens if I wait 3 more months? If you can always wait a couple more months, I always think that's good because a lot can change. World War III can break out. Another COVID could break out. You could get better. There's a lot of things that can happen in time. So I say that if you can buy some time, that's always a great option. The next thing I'd recommend asking your provider is there another, say it's a fusion or say it's a laminectomy, is there another approach to doing this? So say you're like, I know I need surgery, I know I want surgery, ask them. So I see you're going in from the front. Why not do it all from the back? Why not do some from the side and some from the back? Why not do an ablation or burning the nerves? those are questions kind of maybe get them to challenge, get them to know that you know what you're talking about. You're not just walking in there being like, cool, sign me up for surgery. I just want to get better. Challenge your doctor. You need to ask them the questions. Someone keeps asking me, what is radio frequency ablation treatment? They're using nice little X's to get my attention. I appreciate that. We have a lot of people in the chat right now. At one point, it was over 1,000. So there's a lot of comments that come in. So I really do apologize if I don't get to them. I always tell patients or people, if you need to get a hold of me, I have an Instagram. You can direct message me there. Facebook is like less reliable. It blocks a lot, thinking it's spam. So I apologize. I have a YouTube channel, obviously. There's a YouTube way to get a hold of me. All this stuff is the same. Donnally Spine Consult. It's with everything from YouTube to Facebook to Instagram to LinkedIn even, which I don't use as much anymore. But Donnally Spine Consult, YouTube's where I put up a lot of my content, because TikTok's great, but the algorithm targets what you get to see and what you don't get to see. Whereas YouTube kind of views the viewer as the patient, as the person in pain. You got to pick. You can look down these playlists and be like, neck pain. I have neck pain. Let me see what videos. Disc replacements. I want a disc replacement. Let me see the videos. And that's the whole goal of my social media. I really want to give people the information they need so that when they go talk to their general practitioner, chiropractor, spine doctor, they have the tools they need to make smart comments, to challenge the provider, and to really kind of get an idea of why they're even signing up for the surgery or why they shouldn't sign up for the surgery. So that's my whole goal with social media. That's my whole goal doing this, is just getting patients information. I'm not trying to do this as a marketing thing, a recruiting thing, or anything like that. I do see a lot of questions coming through with patients asking how they could talk to me. You can reach out to my office and they can set up a telemedicine appointment. I have a pinned video that shows that also. My group is Texas Spine Consultants, and I appreciate the likes. So I went on a little ramble there, and I didn't answer the most important question someone asked. What is a radio frequency ablation? So I do apologize for going off on a tangent and not answering that. A radio frequency ablation is, I don't know why they say radio, probably has to do with some type of the nerves or the type of frequency, but it's usually it's a pain management doctor. A spine surgeon might do it, but usually the spine surgeon has, their hands are tied with bigger things in a way. But the pain management doctor will put this little needle down into the joint, into the facet. That's where, almost like you have a knee joint or a shoulder joint or an elbow joint. They put a needle down into that joint, and they put a very hot, high temperature probe there that essentially burns the nerves. Now, this is not the nerves that are coming out here. These nerves coming out here give you numbness, give you sensation, give you motor control, give you feedback. These are big suckers. You don't want to mess with these. These are the things that give you pain if you mess with them. So instead, the radiofrequency ablation, instead of getting these nerves here, they get the joints in the back. They get the facets. These facets are the things that get burned or ablated. By doing that, that helps lessen sensation in the joint, and that helps lessen back pain if that's what your source of pain is. So it's a little tough to exactly figure out the source of back pain, and that's why back pain sucks. I appreciate all the likes coming through. That's a good way to help promote this video to other people watching, to other people that are kind of going through the same thing you do. The algorithm knows, and the algorithm will connect to you whether you want to or not, to me or to someone providing good information. So again, the RFA, radio frequency ablation, is when a pain management doctor puts down the needle here and burns out the nerve and the facet, and it creates a lack of sensation and hopefully a lack of pain if your issue is coming from the facet. That's different than if you're having shooting down pain down the butt, shooting down pain down the thigh, down the leg. That would not get better with a radio frequency ablation. So I kind of hate it when I have a really nice patient that comes to see me and they're like, "Doc, I have this pain in my butt. It shoots down my leg. When I'm driving, my leg goes to sleep. My quadricep muscle, your thigh, is buckling on me, and I got injections in the joint." Well, what the heck are they doing? That's just hitting the joint here. That's like saying you're, well, I can't think of a good analogy of the car. I should know more about cars, and then I could use an analogy. But the argument is, if you're having all that stuff I talked about where it's shooting down the leg, down the thigh, down the foot, that's not coming from this joint here. That's extremely likely coming from this nerve or this nerve. So you got to be doing injections at the nerves, not the joints. And again, that's why I hope this social media stuff kind of helps patients make more informed choices and just kind of understand their pathology a little better. One other question I see coming through is, what can I do for degenerative disc disease? Well, that's where one bone is, well, I guess it could depend on what causes it, but usually, disc degenerative is wearing out, and a degenerative disc is when one bone is wearing out on the other, and that could be a source of back pain. It could be a source of this bone giving out on you. And when that happens, these nerves, this one doesn't collapse down a lot, but these nerves collapse down, they squeeze down, it could be shooting down the pain. That's what degenerative disc disease is. The treatment for it is like a billion things. It could be just medications, trying to buy time. It could be injections in the joints to calm down the arthritis in the joints. It could be injections of these nerves to calm down the numbness and tingling of those nerves. It could be, getting a little more aggressive now, a laminectomy. That's where you shave off the arthritis in the back. So that'd be I have a good video of laminectomies on both my TikTok, Facebook, everything, YouTube. So just go there, Donnally Spine Consult, and I really kind of break down what a laminectomy is. But a laminectomy is just a fancy word for a surgical procedure that's a decompression. And decompression, I hate using medical terms, sorry. A decompression is where you take off the arthritis, the compression that are on the nerves. You might hear the term spinal stenosis. That's if you're looking down the spine. All this stuff right here, when it gets squeezed, it's called stenosis. It's tightening of the nerves. So if you can take that pressure off, that'd be great. One way people do it is they kind of lean over a couch, and that takes pressure off the nerves. Another way they do it is they have chiropractors stretch them out. That's a temporary solution. Sometimes that works. Another way to do it is inversion table. So hanging you upside down, pulling those nerves open. Also a temporary way to try to get that done. The surgical way is to make the tunnels bigger, the foramens bigger, as a foramenotomy, or a laminectomy to shave off the middle part. Fusions. I see a question coming through now. What's an XLIF? XLIF, X-L-I-F. XLIF is X-L-I-F. And what that is essentially is going through the side and opening up that nerve tunnel by putting in a cage, putting in a disc space that opens this up. You imagine it's collapsed down. I'm opening it up by putting in a cage. That's what an XLIF does. I like XLIFs. Technically, XLIF is like Kleenex, where it's a brand name for Nuvasive, because it was kind of their procedure first. But that's what that is. So I do appreciate all the likes coming through. That helps promote this to other people. Sorry to echo that again for those that have been sticking with me going through this. I'll kind of go through a couple other questions. Someone was asking about the Intracept procedure. So kind of go the Intracept procedure one more time. I talked about a lot earlier in this video is when you put a needle down and it burns out these nerves here. How to decide between an Intracept procedure versus an ALIF? Well, if you're having shooting down butt pain, shooting down leg pain, you probably would not benefit from an Intracept procedure. Intracept procedure is better for people with just back pain that just sits there in the back, and they have an MRI indicating it's not necessarily the joints back here. It's more so the front bone on bone area and the vertebral bodies. That's more likely when the people that benefit from the Intracept procedure. Again, I don't have any conflicts of interest talking about the Intracept procedure. I don't do it myself. One of the pain management doctors in our group, she does the Intracept procedure. So I think it's a good procedure. She does a lot of. She's kind of one of the first people in the area doing it, so she likes it. In terms of who benefits from that versus a fusion procedure, well, not 100% apples to apples in terms of comparing things. I would say this: the people that for sure are likely to benefit from a fusion are those that have failed non-operative treatment. 2, people that it's kind of a last resort. 3, people that are debilitated by the pain. Okay, so once you get past all those generic statements and you're like, how do I know if that's me? The other indication, sometimes it's when it's severe bone on bone. So it's bone on bone, it's rubbing. When you have to maybe take off the facet, that's the joint in the back. If you take out your joints, then you need stabilization. And the other argument is if you have something called anterolisthesis, where one bone is sliding forward, sliding off the other. That's another indication for a fusion. If you don't have those things, you might not need a fusion. It kind of just varies based on your pathology and kind of what's going on. So I just encourage you to ask your surgeon, why do you need the fusion? So I see another question coming through. It says, why do I recommend patients stop smoking before surgery? Okay, wow, that could be my favorite question of the weekend, and I really appreciate you asking me that. So here's the deal with smoking. We all know smoking is bad for your body, causes cancer. blah, 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 in a way. I'm not disagreeing with any of that, but I'm selfish. And the reason I'm selfish is I care about my surgery I'm going to do on you. And I'm trying to protect you from me, from surgery. There's risk and benefits from surgery. We all know that expression. The reason smoking is so important is because of the risk of surgery. Usually the risk of surgery are here and the benefits are way up here. Well, when you start smoking, one, those benefits actually come down, and two, those risks come up. So it gets to a point where it's too close for comfort, and the surgeon rightfully would not recommend surgery unless you quit smoking. So what are we talking about in terms of the risk or the lack of benefits? Well, your improvement of pain is less if you're smoking. Your improvement of nerve regeneration is less if you're smoking. The other thing that's important with, and I see the question about CSF leak. I'll get to that in a second. So I appreciate that question. Keep coming through. The other important thing with smoking is that if you're smoking, that's a big deal because it could cause increased blood flow in that area. So let me kind of reiterate. Smoking is a big deal in spine surgery. Most spine surgeons want you to quit smoking at least 6 weeks before their elective spine surgery. The risk of smoking, and that's tobacco use, cigarette use, with spine surgery is the following. One, the patients have less improvement of their pain because the nerves don't heal and they don't regenerate as well after the surgery. Two, smoking causes you to bleed more. So you have a higher risk of intraoperative blood loss, which is an issue. And two, that increased blood could lead to something called a post-operative hematoma. That's when you have extra bleeding in that area, and that hematoma could either, if it gets big enough, squeeze the nerves, or if it's in the neck, could decrease your ability to breathe after the surgery, and it could be a emergent surgical procedure to get that hematoma out either in your neck or in your lumbar spine in your lower back. So smoking before surgery is not advised. Many spine surgeons will highly require the patient to have at least 6 weeks of not smoking before they'll do the surgery. And the other thing I haven't even mentioned is fusion, healing. If you're going to get a fusion with rods and screws in the metal cage, if you're smoking, that decreases the rate of healing, of getting that to heal. And if it doesn't heal, those screws might become loose eventually, might create bigger holes in the bone, and you might have to get a second surgery to extend it either up or down. So I usually tell patients they need at least 6 weeks of non-smoking, and I will frequently do a urine test to confirm that, just to, again, help protect you from me prior to doing certain fusion surgeries or certain spine surgeries to avoid complication. So that's the whole deal in terms of why smoking is so important. I told everyone I'd get to CSF leak. A CSF leak is you have cerebral spinal fluid that goes down the middle. A CSF leak is when, there's different reasons. The majority of the time, to be blunt and honest, it's the spine surgeon caused it during the surgery. And I don't think that's, it's not a bad, I'm not saying it's a bad thing. I'm not saying it's a good thing. It's about a 10% risk. So it happens pretty often. And the overwhelming majority of the time, the surgeons put the stitch in it. It's fine. No one ever knew it happened. Not in a bad way, but there's not long-term negative outcomes. The reason I know that, not just from my own stuff, is from there's a trial called the SPORT trial, SPORT, where they looked at this information about long-term consequences of an iatrogenic, that means caused by the surgery, CSF leak. You repair it. Worst case scenario, it keeps leaking out, gives the patient headaches. You go back in, clean it out again. So let me kind of go through again and just reiterate in like a nice, concise version of CSF. CSF is the cerebral spinal fluid. When you have a CSF leak, that could either be from the surgeon nicking the dura and creating a CSF leak. It could be from a bone spur impacting the thecal sac, creating a spinal leak, or it could be from a trauma where the bones moved and in that traumatic car accident, fall, fracture caused a CSF leak. In the overwhelming majority of cases, the spine surgeon will use a small little stitch to repair that little pinhole in the spinal thecal sac. Once that pinhole is repaired, the long-term ramifications of a CSF leak caused in the surgery is negligible. So that's a really good thing. Someone else is asking about a foot drop from sciatica. That's definitely the case. The best way to fix a foot drop is to diagnose the cause. Usually it is from the spine, but sometimes it's not. It could be something in the leg, could be a tendon rupture, but that's kind of the main thing. What is narrowing of the spinal canal? I like this guy or girl using X's. It helps me see their comment more than others. Narrowing of the spinal canal is this middle part here. It gets pinched, it gets narrowed. That's narrowing of the spinal canal. Again, I appreciate all the likes coming through that, not to play into the algorithm, but it shows other people that there's good information coming through. And if you like it, it'll get popped up on other people's channels and pages that they should look for it. So I do really appreciate it. And then also, I try not to talk about it too much, but I have a handful of patients, even in the chat now, a handful of patients who are asking questions, who are singing praises, which I really appreciate that. Can spinal stenosis be cured? 1000% yes, because spinal stenosis is squeezing of the nerves. So curing it is just opening the nerves. Now, if you ask me, can back pain be cured? Can a foot drop be cured? That's a little tougher for a couple things. One, diagnosing the back pain is a little tough. If it's like, you got to figure out what's causing the back pain. So if you can for sure pinpoint what's causing it, then I guess you can cure it. In terms of foot drop being cured, well, there's a timeline on there where it only gets better after a certain period of time. So that's not as likely. Can sciatica or radiculopathy, shooting down pain, be cured? Yes, usually that can be cured. And that's kind of what I was talking about before in terms of the Intracept procedure. That procedure, again, I don't do it. I have no financial ties. That they put the needle in here and they burn the nerves in the bone. That's a great way to help lessen back pain if you meet all the criteria. Versus if you do have the radiculopathy, the shooting down pain. Well, if you have that shooting down pain, you shouldn't get the Intracept procedure. You might benefit from a fusion. That you might benefit from an ALIF procedure, the anterior lumbar interbody fusion. So it all just kind of depends on what your symptoms are. There's a lot of people out there who have had spine surgery and they don't have great outcomes, and that sucks. It's like if I went to a restaurant and had a bad meal, I'd probably tell a lot of people. If I had a good meal, I probably wouldn't tell too many people because I don't think too many people would care, and it's not that interesting of a story. So in general, many people do fantastic from any surgery, including spine surgery, but it's a pretty tough thing to do. It's a pretty tough profession. So the key thing I always tell people is you need a diagnosis. Once you have confirmed diagnosis, then you can better treat things. I know that sounds like a very silly thing to say, but that's how you keep things minimally invasive, how you keep surgeries at times outpatient overnight, because it's small incisions, it's small surgeries, and that's kind of the whole goal. I'm not trying to do an all-day 10-hour surgery. I will when needed, but if I can do a little chip shot 90-minute procedure to take you from 9 out of 10 pain to 0 out of 10 pain, why would I not do that? So that's kind of my philosophy. And it's not me being any special than anyone else. That's what I would say the majority of spine surgeons' profession is kind of small outpatient short surgeries. So I do appreciate everyone kind of sticking with me, listening to my stuff today. On that note, I am going to run. If you have additional questions, please subscribe to my videos, particularly on YouTube. That's where I have most of my content because I can do longer form content on YouTube. It's Donnally Spine Consult. The subscribes are how you can kind of see the new things coming out. The TikTok's really important also. Facebook, Instagram, pretty much where I do something on one of them, I put on all the others with just a few simple clicks. But the longer content, the more informative stuff is on the YouTube stuff. And that's Donnally Spine Consult on YouTube. So again, I really appreciate everyone kind of asking questions. I do really apologize that I don't get to all the questions. A lot of people will ask it 20 times and I won't get to it. It's just they come up so fast. And hopefully if you watch the YouTube stuff, you can circle back because I do live stream all this to YouTube and you can see me answering it previously because to be blunt and fair, a lot of these questions are asked multiple times. So if you have a question, you're not too unique. Other people have asked this question before. So on that note, I really do appreciate it. I got to go